everybody. I'm Stuart Schlossman from MS Views and News. This is what we call the Compass MS Care program. We are sponsored tonight by Genentech, Sandoz, EMD Serono, TG Therapeutics, and Novartis. And each of these companies appreciate the work that we're doing in the United States, providing for those that need these programs most. Tonight's program, all right, for those that don't know Dr. Boster, he's with the Boster MS Center in Columbus, Ohio. He's on the northern end, near the northern perimeter, whatever it's called up there. Let's see him run on up. And let's congratulate him for being here. He's going to speak with you about the immune system, right? Take it away. You may hear him talk in two different roles.
Howdy. No, come on, guys. That was a very mediocre performance. All right, so what I just did is called an audience participation maneuver, all right, where there's a call and then a response. So I'll say howdy, and then you say howdy back. Are you ready? Yeah. All right, thank you. Howdy. Woo! Now, this is being recorded and watched throughout the globe, and so I want everyone to know where we are. OH! 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 Thank you. Careful and give them back to your car partner. No, I'm just teasing. I am absolutely delighted to be here, and Stuart wants to put baby in a corner. I'm stuck in a square. All right, thank goodness. That's a lot better. Oh, thank goodness. Okay, all right, no, I'm just joking. So thank you very, very much for giving up some time in your evening to come out here and to up your game. It's my goal that we can energize and empower and educate families impacted by MS, and I am super delighted to be invited back with MS Views and News so that I can talk to all of you. So can we start by saying thank you to MS Views and News for creating this program for us? These guys travel all around the United States to cities all over the place, and they come back here, and that means the world to me. I also am so proud of Caroline. I met her when she was a graduate student. She came and spent some time with us at the MS Center, and I just think it's awesome to see what she's done. So can we say thank you to her again? Thank you. So tonight, I wanted to talk a little bit about the immune system. So there's lots of different things that you and I have talked about over the years. And tonight, I really want to spend a little bit of nerd time with you discussing how the immune system works, how it gets mucked up in the setting of MS. And then I thought we would go through every single drug FDA approved for MS, and I'll explain to you how they work. And then it'll be time for me to go to work in the morning. No, I'm going to do it like very, very succinctly, okay? So if that doesn't sound fun to you, good luck sneaking out, because I can see you. No, I'm just teasing. Let's take a dive into what the immune system is and how it works normally, and then what happens in the setting of MS. There are many different systems in the human body, right? So we have, for example, like the cardiovascular system that pumps blood around your body. And then we also have like the lungs, right? So the pulmonary system that like gets rid of carbon dioxide and gets oxygen in, all these different systems in the human body. The immune system is the army or the mall cops that make sure that there's no bad guys invading us, okay? So if you imagine a bunch of mall cops kind of tooling around a mall and they're just making sure that the patrons are okay and not bothered by hooligans and that there aren't shoplifters and things like that, that's what the immune system is supposed to do. Now, I asked my brother, who is a United States Marine, and he confirmed that you're not supposed to shoot your buddy on guard duty. And he was very firm about that. No friendly fire, he said. And that applies to the immune system under normal circumstances. So when the immune system is doing its tour of duty, and it's tooling around the human body, it's checking out everything it sees. Just like a mall cop walking around the mall, kind of checking everyone out. And if it sees one of its own cells, it says, well, hello, me. I'm delighted to see me today. How is me, right? And it leaves it alone. Now, if it sees a virus or a bacteria or a fungus or a parasite or some bad guy, then it gets activated. And we'll talk about exactly how that happens. And it learns that bad guy, and it tells all its friends about that bad guy. And then for the rest of the human being's life, if the immune system sees that bad guy, it attacks it. So in this analogy of mall cops, if you had a serial shoplifter, right? And so they had a picture of him and they put it up on the bulletin board. And so all the mall cops could look at it and be like, that's a bad guy. And now they've got it in their brains. They're walking around, and if they see him, they can react very, very quickly, right? So that's the way the immune system works under normal circumstances. And I'm going to make it slightly more complicated because the immune system is a bunch of different cells. It's like almost like an alphabet soup. So if you think about the immune system, we're going to break it in half. There's the innate immune system and the adaptive immune system. The innate immune system is like cavemen, right? They're ever ready. They attack on sight and they can learn nothing, right? So they're kind of like dumb as rocks, but they're sitting there and they're ready. And as soon as a bad guy comes in, they pounce on it. And there are immune cells that are part of the innate immune response, and they're very, very helpful because they respond lickety-split when you get the flu. They respond right away when you get an infection. But they're not specific, and you can't teach them to do anything different than like beat a guy with a club. The adaptive immune system, that's the other half, can't start right away. The adaptive immune system reminds me of like a college freshman. They don't know what they want to do when they grow up. They're going to do something, we hope, but we don't know what yet. And the adaptive immune system can learn from the innate immune system. The innate immune system kind of shows them, hey, look what I just beat up. And they can see that, and then they can start to develop a response to that same bad guy. Now, the adaptive immune system has two parts. There's the humoral immune system, and those are the B cells, right? And then there's the cellular immune system, and those are the T cells. And so this room is split in half. And we're going to divide the room into the T cells and the B cells. If I say the word T cell, you're going to scream. And if I say the word B cell, you're going to scream. So just randomly, if I said B cell, not you, over there. All right, so we're going to try it again. So if I were to say B cell, awesome. And then if I were to say T cell, that's fantastic. You realize there's people online going, what? So we're going to talk about the B. Come on now. We're going to talk about the B and the T cells. And I want you to understand how they're involved in this adaptive immune response. The T cell is the fighter. Oh, that was good. I didn't even plan that one. Woo, this is going to be good. So the T cell is the fighter. That's the actual guy that's going to beat up on the bad guy. The T cell needs a B cell. This is so much fun for me, to help it, because the T cell by itself is not capable of doing the attack adequately. It needs to be co-stimulated by a B cell. And so when you have the innate immune response that sees a virus and attacks it, and then tells the adaptive immune system, guys, we have an invader, the B cells stimulate the T cells, and then the T cells learn what they need to learn. Oh my goodness gracious. And then they tool around the human body. Now, once that is set up, you don't have to remind it very often. So when the doctor says you can't get chickenpox twice, she's lying. You can get chickenpox 100 times. The first time you get chickenpox, the innate immune system sees it. It tells the B and T cells, and then the B cells stimulate the T cells, and your T cells remember that for the rest of your life. All right, we can stop. I'm having way too much fun, but thank you. That was awesome. I thought about that all day in clinic today. I was like, I have an idea. Okay, so once that's set up, you now have adaptive immune system cells which have differentiated. They've specialized. They're no longer college freshmen. They're now specific and able to attack the chickenpox anytime they see it. And so you have these adaptive B and T cells floating around your body, and they're primed for chickenpox. So the second time you get chickenpox, the immune system has been waiting since you were 12, and it pounces all over it and clears it out very quickly, so you don't experience an infection. Does that make sense? Now, I want to revisit that in the setting of multiple sclerosis, because multiple sclerosis is an autoimmune condition. The words autoimmune mean that your immune system made an error in judgment, and it, by accident, identified part of your body as a foreign invader. Where's Stu? All right. And when that happens, The innate immune response and the adaptive immune response, both the B and the T cells, learn the wrong thing. They learn that that part of your body is a bad guy. And so once they learn that, just like if they learn about chickenpox, they don't know how to unlearn it. And so every time they do their tour of duty and they're looking around at all the different cells and whatnot, they see self, but they don't recognize it as self. They think we're looking at a bad guy, and they do what they were trained to do, and they attack it. Now, there's lots and lots of different autoimmune conditions. So if your immune system attacks your pancreas as a child, we call that type 1 diabetes, where you lose the function of your pancreas, you don't make insulin, and then you need to take extra insulin to keep your sugars okay. That's an autoimmune disease that affects the pancreas. If the immune system attacks the joints of the hands and feet and can cause destruction of those joints, that's called rheumatoid arthritis. That's an autoimmune condition. And there are a lot of autoimmune conditions: lupus, Sjogren's, rheumatoid arthritis, Crohn's, childhood diabetes, psoriasis, sarcoidosis, myasthenia gravis. There's a bunch of them. Multiple sclerosis is an autoimmune condition where the B and the T cells, the B and the T cells by accident learned that the central nervous system, the brain, the holiest of holies, the supercomputer that runs the body, and the spinal cord, the superhighway that takes the information from your brain down to your tootsies and then back up, that's a foreign invader. And once it learns that, it can't unlearn that. Now, we've actually learned a little bit more since the pandemic. We've confirmed a theory that we now have a good sense of how the immune system makes that mistake. So, show of hands if you missed some school because you had the kissing flu, you had mononucleosis, you have glandular fever. So some people missed school. Most people get EBV or mono and they don't miss school. Sometimes it's really bad, not all the time. And there was a study done in the United States with 10 million people in the military. It was a really, really, really large study done by the Veterans Administration teams. And they looked at 10 million folks in the United States, and they looked at how many of them had Epstein-Barr virus. Had they ever been exposed to EBV, ever? And 95, almost 96% had. Right? Which means it's a really good virus because most Americans are exposed to EBV. In that giant population were about 800 people that had MS. And there, 99.8% of them had been exposed to mono. And when you're dealing with populations that large, that's actually highly statistically significant. And it kind of confirms a suspicion that we had going back to the 60s that probably what's happening is your body sees mono, EBV, which is a virus that's a bad guy, and your immune system identifies it as a bad guy and tells the B and T cells, hey, there's a bad guy, and the B and T cells make an arsenal against EBV, which you keep for life. Here's the problem. Some of the proteins that make up the virus EBV look just like myelin. And when you make that arsenal against EBV, it by accident binds to myelin perfectly. It's kind of like if I got a copy of my car keys made, and for some weird reason, it also unlocks your car, right? And once that key's made, anytime I open your door, I can just open it. Once the immune system makes that error in judgment, and it thinks that the brain and spinal cord is Epstein-Barr virus, it doesn't forget how to do that. And that's the underpinnings of multiple sclerosis. So in quick summary, we're going to divide the room in half. Let's think about how we're going to do that. May I use that as a prop, pretty please? Okay, thank you. This is gorgeous. All right, so this is the blood-brain barrier. Ho-ho. All right, and then over here is the brain and spinal cord, the central compartment. And then over here is the bloodstream. So what happens in the setting of MS is the naughty autoreactive cells, they live in the bloodstream. That's where they hang out. And they leave the bloodstream and they cross into the brain where they see it's their target, the brain and spinal cord, and they attack it. And they attack it with inflammation. So if you've ever fallen and bumped your arm and then your arm gets all swollen, it's inflamed. Or if you were involved in fisticuffs and took a punch and your face gets all puffy, that's inflamed. And inflammation, it brings water in, and it brings those cells that we've been talking about in, and then they attack the tissue, except the tissue is your noggin. You're using it to do things like think and move. That's the underpinnings of multiple sclerosis. Now, the reason I wanted to share that with you is because I now want to talk about how we take advantage of that system to break it to help slow down the disease multiple sclerosis. When my Uncle Mark had MS, there were no medicines for MS. He was fixed in a wheelchair and couldn't move his arms when the very first drug came out in '93. And he didn't hit the lottery. There was a lottery because they didn't make enough of it, and so he didn't get to have it. And later they came out with a second drug, and he took it, but it was way, way too late for him. That's not the case anymore. I saw 3 people in consultation today, and they're going to have a very, very different life experience because we've learned how the immune system works, and we've learned how to mess with the pathology that I just described to you. So let's spend a few minutes, and I'll share with you what we've done. And by the way, we've done a lot. So 1993, the very first MS medicine was FDA approved. That was beta-seron. All right, that's one of the interferon beta products. Today, as I talk to you in 2024, I can count 28 different formulations of MS medicines. And at the Boster Center for MS, we're doing no less than 10 clinical trials studying many, many new medicines. And so it's a very robust and exciting time. And when I say, if you have to have MS, now's the best time to have it, I'm not wishing it upon someone. But the reason I say that is because of all the things that we can do to make it really, really boring. And so I want to empower you with some information about exactly how we do that. The short and the long of it, every single drug I'm going to talk about either kills the cell in the periphery, kills the cell in the central compartment, retrains the cell to knock it off in the periphery, or blocks the cell from getting across the blood-brain barrier. All right? And thank you, sir, for letting me borrow this. So let's start with the oldies but goodies. Whoops. So we're going to start with what we now call the platform medications. And these are typically self-injections. It's what we started off with. And we'll start by talking about gluteramine acetate. Right? So that's Copaxone and Glutopa. And gluteramine acetate is an injection that you give yourself typically like 3 times a week. And that injection in the vial has 4 amino acids in a random order, G, L, A, and T. Those are the 4 amino acids. And they're in a secret ratio, which Teva won't tell us about, and they mimic myelin. So those structure, that polypeptide, looks like your myelin. So when you inject gluteramine acetate into your body, it floats around your bloodstream, and your immune system checks it out. So what's that? And then a couple of days later, you do it again. And then a couple of days later, you do it again. And what you're doing is you keep making the immune system look at its target. And again, 3 times a week, look, see it? Now look, see it again? Look at it again. And it gets bored. Like quite literally, it gets immunologically bored. So instead of, when it crosses the blood-brain barrier, so we're going to go from the periphery into the central compartment, and it sees real myelin, it doesn't care. Not as much. And instead of causing a pro-inflammatory bust the situation up, no, it does an anti-inflammatory cascade. And so that's the way that gluteramine acetate works. By tolerizing the peripheral immune system to knock it off and care less, so when it enters the central compartment, not so many things happen. That's one. We only have 27 more. We're doing great. No, I'm just joking. I'm going to do this in classes. So the next bucket that I want to talk about are the class of medications called the beta interferons. So beta interferons include several different medicines. Beta-seron was the very first one out. Xtavia is basically beta-seron. Rebif, all right, we have Avonex and Plegridy. So there are 5 interferon beta products, and they're all self-injections. Some are every other day, some are 3 times a week, some are twice a month, some are deep in the muscle, some are in the skin. But they all work the same way. What they do is they tighten the blood-brain barrier. So that barrier, the blood-brain barrier, where the cells in the periphery have to cross into the central compartment, they cross this barrier. And I want you to think of the blood-brain barrier like the 3 little pigs, like the straw house. Not a very good house. Pretty darn easy for the cells to go back and forth. If you take interferon and squirt it on the blood-brain barrier, it turns into the stick house. It's a better barrier. So it makes it harder for the naughty autoreactive B and T cells to cross the blood-brain barrier because you made a better barrier. That's the way that interferons work. By the way, interferons are actually made in our bodies. They're part of the innate immune response. When you get the flu, interferons are one of the first things that are made, and it's the interferon that makes you feel flu-like. The flu bug doesn't make you feel bad. The interferon, which is fighting off the flu, makes you feel like poo-poo. So as you can imagine, the side effects of interferon products, if you bottle that and inject it into you, people oftentimes experience a flu-like symptom because you're giving yourself the part of the immune system that makes you feel that way. Wah, wah. So that's how the interferon beta products work. Next, I want to talk about Natalizumab. And one of our sponsors today makes Natalizumab. So see the Tyruko rep over there? Wave to her, make her feel really good. Wave to her, come on now. And Natalizumab, all right, and so there's two different kinds. There's Tyruko and there's also Tysabri. These are infusions in the vein. Okay, why are they infused in the vein and not taken by a shot? Because they're engineered antibodies. They're very, very large structures. Okay, you can't swallow them because the antibodies are made of protein, and when you stick protein in your stomach, like you just did at dinner, it dissolves, right? And they're really large, so they have to infuse them into your vein. And Tysabri or Tyruko, these Natalizumab products, what they do is they take the straw house, the blood-brain barrier, and they turn it into the brick house, right? They make the Great Wall of China. And so they make such a profound barrier that your cells cannot enter the central compartment. So you have very naughty autoreactive cells that would be very happy to attack the brain and spinal cord if they could simply get over there, but they can't. They push all the cells out into the periphery and just leave them there. They can float around, do whatever they want, but they can't get into the brain. Now, there are some advantages and disadvantages to that mechanism. During the COVID-19 pandemic, people on Tysabri mounted normal responses to vaccinations, and people on Tysabri, Tyruko, Natalizumab, they were able to fight off COVID very easily because the peripheral immune system wasn't affected. It was normal, right? If the Tysabri were to have if the COVID had gotten into the brain, maybe then it wouldn't be able to do it. But most of the patients that we had on Natalizumab fared very, very well. Now, you've heard of this concerning virus called the JC virus. And the JC virus is a virus, and it's not a very good one. It's actually a pretty crappy virus. Now, half of people over 30 have been exposed to JC virus, and we don't care. It's such a bad virus that our immune system on its way to work just like kicks it in the teeth every single day, just beats up on it, no big deal. Unless you take a medicine like a chemotherapy for an oncologic cancer or Natalizumab, then sometimes that JC virus can cross into the brain and there's no cells to check it. There's no mall cops. And it can have a heyday and it can cause a very serious infection, which can be fatal and called PML. So that's how Tysabri works. Next, let's talk about the pills. So I remember very, very vividly October of 2010 when the very first pill came out, and what a big deal that was. Because prior to that, we had to try to be like cheerleaders and talk patients into jabbing themselves, and it was awful. And so when pills came out, that was really amazing because now, instead of having to jab yourself with a needle, you could just swallow a pill. The first pill I want to talk about is called teriflunomide or Aubagio. Right? So teriflunomide is not an immunosuppressant molecule. It's not dampening or suppressing the immune cells like some of the drugs do. What teriflunomide does is it makes the T cell in the periphery very slow to make copies. And so normally when the immune system's activated, the first thing that happens is the T cells replicate. So you've heard of that movie called Star Wars? Some of you have? Yeah. So in the movie Star Wars, the Republic needs to create an army. And so they take this guy and they clone him and they make them all wear white hats. Those are the stormtroopers. So they make millions of stormtroopers like right away and suddenly they have an army. That's what your immune system tries to do when it gets stimulated, is it starts to make massive copies of one another. And when you take Aubagio, you can't do that. It doesn't kill the cells at all. It just makes it so you can't rapidly mobilize them. You keep making copies of them. And we don't see a very significant risk of infection with this medication, but it sort of makes the white blood cells play the freeze game while you're taking it. And so they can't rapidly reproduce, then go out and attack you. And that's the way that Aubagio works, which is pretty darn neat. The next class of drugs I want to talk about are the S1P1 receptor modulators. Now that's a mouthful, and I didn't make up these words. I just had to learn them at one point in time. The S1P1 receptor modulators are pills. The very first one was Gilenya, right? So that was a pill that came out that you take once a day. And now they have 3 second-generation S1P1s, which is really, really great. So we have Zeposia, we have Mayzent, and then we have Ponvory. So there's actually 4 of these medicines in this class. And they are amongst the weirdest of all the medicines. They work in the periphery, and when the white blood cells are doing their tour of duty that I was talking about, I didn't tell you the whole truth. They don't spend most of the time in the bloodstream. They literally leave the bloodstream, and then they go in the lymph nodes. So think of the white blood cell as a car, and the bloodstream's the road, and the lymph node's like the garage, right? So the white blood cell goes down the bloodstream, and it takes a pit stop in the lymph node. And that's where it learns stuff and talks to it would be like a bunch of guys with classic cars getting together in a parking lot and kind of kibitzing and talking and whatnot. And they learn things, then they leave and they go back out on the road. The way they exit the garage is by showing their hang tag. They have to show a hang tag, and then the door opens up, they can leave. When you take Gilenya or any of those S1P1 receptor modulators, it steals the hang tag. It makes the hang tag dissolve. So you go into the lymph node just fine, and you can't leave. It traps 80% of those B and T cells that were floating around in the lymph nodes, and they can't escape. So it makes me think of like the Eagles Hotel California. You can go in, but you can't leave. And so as long as you keep taking the medicine, it traps those cells in the lymph nodes. And if the cells are trapped in the lymph nodes, they can't get into the bloodstream. And if they can't get in the bloodstream, then they can't cross over into the central compartment and attack you. If you stop those medicines, then the cells are free to kind of move back out. And we never want to stop those medicines abruptly. Because if you stop those medicines abruptly and you don't do anything else, they will bum rush out of the lymph nodes, and they can actually cause MS to get worse. That's called rebound. And so it doesn't mean you can't get off the medicines. You can. You just have to let me help you so we can do it safely. All right, and if we do it safely, then no harm, no foul. Now, the next category of medicines I want to talk about are the fumaric esters, right? And there's 2 medicines. One's called Tecfidera. Some of you have heard of it because I put you on it. And Vumerity, all right? And so those 2 medicines are pills taken twice a day. And what they do is really interesting. They trick the immune cells into thinking they're under oxidative stress. So they respond with an antioxidant cascade of loveliness, which quells the whole inflammatory environment, all right? It would kind of be like in the mall playing soft music and having some sweet perfume and, giving everyone snacks so they don't get upset and fight each other. And quite literally, when you take dimethylfumarate Tecfidera or diroximel fumarate Vumerity, it works by changing the inflammatory milieu and creating an anti-inflammatory environment that helps MS. You may have noticed that so far in everything I've talked about, it's all been about T cells. Because when I was in school, we thought MS only involved T cells. We actually didn't realize how much B cells were involved. Now we've learned, which is great, and it turns out that B cells are very involved. And I didn't tell you the whole story earlier either. Gosh, I keep fibbing. So when the T cell goes to attack you, it needs the B cell to stimulate it. And if we kill the B cell's not available to stimulate the T cell can't attack you. It turns out that mechanism is really, really effective in treating MS. And there are now several medications that work by depleting or killing B cells in the periphery, in the bloodstream. These are medicines like rituximab, Rituxan, ocrelizumab, which is Ocrevus. All right, there's a medicine, Kesimpta, which is a self-injection taken once a month. And there's a fellow over there representing Novartis, so wave to that nice guy. You can wave to him, he's lovely, right? And then there's a new one that came out called Briumvi, right? And so these medications, they work by identifying adult B cells and murdering them. When you murder the adult B cells, if you don't do anything else, in about 6 to 9 months, they're going to grow back, which is why we give you a lot of those infused medicines twice a year. So we keep suppressing the B cells. As long as we keep the B cells suppressed, they're not available to piss off the T cell to go in the brain and attack you. And that's an indirect mechanism and it's extremely effective. But it increases risk of infection. One of the things that we learned during the global viral pandemic, COVID-19, was that people that were on the S1P1s, the Gilenya medicines, and on the B cells, they weren't able to fight off the infections as well. And they weren't able to mount new vaccine responses very well. Because if you suppress all the B cells, they're not available to make new vaccine responses. All right, and so that became very, very tricksy. And so we're now gonna start to wrap up. There's a couple other drugs that are FDA approved, and they're kind of my faves. And there's two that are both in a class which are definitely the weirdest of drugs because they're not taken very often. Most drugs you take all the time. So I have high cholesterol, thanks mom and dad, and I'm supposed to take a cholesterol pill every night to lower my cholesterol, to decrease my risk, God forbid, of a heart attack or a stroke. And I'm supposed to take the cholesterol medicine every single day, right? Because if I stopped taking it, then my cholesterol would go back up and then I would have a higher risk of stroke and heart attack. That's a continuous medicine. Most medicines are continuous. Every medicine I've listed so far, you take all the time. You take Tarico, you do that once a month, all right? The Ocrevus or the Briumvi or the Rituxan infusion is every 6 months, all right? The Vumerity is twice a day. But there's a couple medicines that are not like that. There's a medicine that I'm very fond of called Limtrada, all right, or Alemtuzumab. And Limtrada is a pretty big gun. It works in the periphery, and it identifies the adult B and the adult T cells and destroys them and makes them grow back more well-behaved, right? So imagine that you had some naughty young boys in class that misbehaved all the time, and they would pull the girls' ponytails, and they would get in fights, and they would throw ink around, and they were really, really destructive. So instead of killing them, you ship them off to boarding school, to military school for 5 years, and they come back and they stand at attention. They say, yes, sir, and they open, the door for someone when they walk in and they behave themselves. You knock them out and you retrain them to behave themselves. And Alemtuzumab or Limtrada is given for 5 days in a row, and then you don't do anything for a year. And then 3 days in a row, and then you don't treat ever again unless you have new disease activity, which is super duper weird. It's a discontinuous medicine. In my experience, it's a very, very, very effective medicine. It's also absolutely the most complex. It has the most risk profile. And in the United States, much to my chagrin, it's kind of fallen out of favor, not because it's not effective, it's highly effective, but because it's very, very complex and there's lots of risks associated with it. There's another drug which is also discontinuous, meaning you don't take it all the time. And that drug is called Mavenclad. And there's two guys over there. One of them's really, really tall, all right? And the other one's like of a normal height. And they both work for a company that makes Mavenclad. So we'll wave to those nice fellows over there. And Mavenclad is a pill that you take on Monday, and then on Tuesday, and then on Wednesday, then Thursday and Friday. And then you're done for the month, which is weird. I joke it's like reverse birth control, right? And then that's month one. And then on month two, you repeat Monday, Tuesday, Wednesday, Thursday, Friday. And then you're done for the year. That's pretty weird. So you take 10 pills the first year. And then a year later, you repeat that process one time. 5 pills the first month, 5 pills the second month. Then you're done for life unless you have new disease activity. Again, that's very strange. So when you think about all these medicines, this Limtrada and this Mavenclad work very, very differently. Both of them are rebooting the immune response. Now, to talk a little bit about how Mavenclad works, it doesn't really attack both the B and the T cells the same. It really focuses on the B cells, and it doesn't knock them down to nothing. It just kind of pulses them down and then back up. So I always think if you're driving 80 on the freeway and you see a cop, you slam on your brakes real quick, and now you're going 60, shh, right? And you just kind of do it a little bit slower. I saw that on TV. And so when you do that, you reboot the immune system. When you knock down the B cells, you remove the B memory cells, and they only come back 13%. So you're removing some of the immunologic memory. This is how these weirdo drugs can be given for a short period of time and then work for a very, very long time afterwards. And that is in a span of, I hope not that long, we've gone over every single mechanism of every single drug that's used to treat multiple sclerosis. Now, before I open things up to questions, I thought I would now do the exact same thing and explain the new medicines that are coming down the pike. Would that be okay? So just quick like a bunny rabbit. So at the Boster Center, I mentioned that we're doing a bunch of clinical trials, and these are global trials. They're done all over the world. So there's centers all over the world asking families impacted by MS if they would volunteer to help us figure out what's the next best thing. And I want to take a moment before I explain them, and I want to thank human beings with MS who came before us, who volunteered to participate in clinical trials. Because if no human volunteered to do a clinical trial, we would have 0 drugs right now, right? So can we say thank you to them? That's a really, really big deal. That's a really big deal. And so let's start by talking about a new class of medicine that we're very, very excited about, and this is called BTK inhibitors. All right, now, when I first mentioned at home BTK, my ex-wife said, oh, bind, torture, kill, which freaked me out. So I didn't know this, but there's an American serial killer named the BTK killer, and that has absolutely nothing to do with what I'm talking about. So put that out of your head. So BTK stands for Bruton tyrosine kinase. I didn't make that up. Go back to the B and the T cells, okay? When the B cell is stimulated, on the outside, the receptor gets stimulated, it triggers a cascade of machines inside the B cell. Like machine 1 starts machine 2, starts machine 3, starts machine 4, and then the B cell does some stuff. And in the setting of MS, that stuff is bad. The BTK is one of those little machines inside the B cell. The BTK inhibitor goes into the B cell and breaks the machine. So now when the B cell is stimulated and it goes inside the B cell and the first machine is activated, it goes to stimulate the second machine and that one's broken. And so it stops the B cell from being able to do its job without murder, right? So that's really interesting because what happens is the B cell can't communicate to the T cell except it's not dead. And so the reason that's so darn attractive to me is we can have a benefit to MS without increasing risk of infection. It gets even better, in my opinion, because that's not the only cell. It doesn't just work on B cells. Remember about 40 minutes ago, I mentioned the innate immune system? You know, I haven't mentioned it once since then because it wasn't until now that we could touch it. We couldn't get to it. We knew it was involved in MS, but we couldn't get at it. These BTK inhibitors can cross from the bloodstream. They easily enter the brain. It's no problem. And there are these cells that I haven't talked to you about called microglia. They're part of the innate immune system. And they eat stuff. And when they get upset, they eat lots of stuff. And in the setting of MS, they eat your brain. And that's bad. I learned that in doctor school. And so these BTK inhibitors, they enter the microglia and they break it just like they do B cells. And so the microglia can't start eating your brain, which is really, really cool. Now, BTK inhibitors are not FDA approved for MS. They actually are FDA approved for other things like cancer, but we're studying them in clinical trials and the jury's still out. Some of the trials are starting to get results. Some of them have worked and some of them haven't. Just to talk about that very briefly, we've now had results on 3 trials. 2 trials studying relapsing MS, so people with MS who have relapses. And in the trials, we pitted the BTK inhibitor against Aubagio. And in both trials, it didn't do better than Aubagio. It was a negative trial. And that means that those drugs are probably not going to be approved for relapsing MS. That's why we do research, guys, so we can figure that out. There's a 3rd trial that just was presented, and I'm very, very proud that I was involved in this trial, called the Hercules trial. And in the Hercules trial, they didn't enroll people who had relapses anymore. They enrolled people who used to have relapses, but they hadn't had them in on average 7 years. And they were getting worse in their disability. And we call that non-relapsing secondary progressive MS. And it worked. As compared to placebo, we were able to slow down non-relapsing secondary progressive MS by 29%. We've never been able to do that in the history of the universe. And so that's very, very exciting to me. And I predict, although the FDA hasn't called me yet, that the FDA will approve that medicine for that indication. Now, we're also studying BTK inhibitors in PPMS. And the first PPMS trial, the Perseus trial, will be reported out in 2 months. And so as you can only imagine, I'm very, very excited and encouraged about that. Let me take you past the BTK inhibitors to the next wave of innovation. There's a drug called Frexilizumab. I swear to God, I didn't make up these terms. And we're studying at the Boster Center Frexilizumab in several different trials. Now, Frexilizumab, or I'm going to call it Frex because that's super weird, is an infusion in the vein once a month. And how does it work? So I'm going to use, okay, would you come here and help me? Can you come here and help me, sir? Come up here real quick. It's not going to hurt, I swear. All right, so this gentleman is a B cell, right? And this nice lady is a T cell. When the B cell stimulates the T cell, they literally do it by touching, okay? And so can you guys go like this? We're going to Yeah. So they're going to like slide your fingers in there. And that's when that happens, when this happens, that's how they communicate. Okay. Now, what Frexilizumab does is it binds this part of the B cell like this. So it doesn't fit. Literally, it binds this up so that they can't communicate. So it doesn't break the inside of the cell, it just makes the arm not able to communicate with the T cell, and it prevents B cell, T cell communication. Can we give them a round of applause? That was really nice of them. It prevents B cell, T cell communication without murder. And right now we're doing several trials studying Frexilizumab. So the future is very, very bright. And there's no quiz, but it's my hope that over the last half an hour or so, I've helped you understand, sort of like Immunology 101, with the immune cells being the innate response and the adaptive response with the cellular, the T cells, and the humoral, the B cells. And then I hope that you had a little bit of insight into how the immune system makes an error in judgment. And those cells identify your brain as a foreign invader. And once they learn that, they don't know how to unlearn it. And we've now talked about 28 plus 2, 30-some medicines and how they interrupt that to help people with MS live their very best life and to slow the disease down. So thank you very much for your attention. I'm honored that I got to speak to you today. And we're now going to do a Q&A session. Thank you again.
Awesome. Again.
And I mostly stayed in my little
Awesome
square.
Again. That's not a square, it's a rectangle. Okay. You got to do that in biology or trigonometry or something like that, we didn't do that, right? Yeah. All right, great. Anybody out there have questions? Awesome. I got to get to you though. So while I'm getting to you, I want to ask you though, aren't there also biosimilars out there?
Yes. Let's talk about biosimilars for a second. So when you make a drug, there's different kinds of drugs. There's small molecules that are typically pills, that are chemicals. Okay. And then there are biologic agents. All of the infused monoclonal antibodies, so that's like Teruco, that's like all of the B cell depleters, they're all monoclonal antibodies. They're antibodies like made in a laboratory, but they're biologic. They're made up of proteins, right? And that's called a biologic agent. Now, when a drug is made, the first time it's made, they call that the innovator or like the original. Okay. And then after a certain number of years, the manufacturer that made that drug, they lose their patent. And now other manufacturers can create the same monoclonal antibody and it'll do the exact same thing. And so that's called a biosimilar. So you have the biologic originator and then you have the biosimilar. And something that I like very much about biosimilars is we test them in human beings before we give them to patients. So we're required to do clinical trials to prove that the biosimilar is as safe and as effective as the originator. So remember when we waved to that gal over there with the Natalizumab? That's a biosimilar. And they did a trial called the Antelope trial, where they put people with MS on either the Tysabri Natalizumab or that one, and they followed them, and then they switched them, and nothing bad happened. All of them had the same risk of PML. All of them had the same benefit to their MS. And that makes me feel very confident that that's going to be a very effective medicine. Right now at the Boster Center for MS, we're studying a biosimilar for ocrelizumab. And the people that enroll in that trial are getting an infusion twice a year. Half of the people, it's Ocrevus, half the people, it's the biosimilar. And we're going to prove that it works equally as well. Why are biosimilars so good? There's a cost savings with the biosimilar, and that makes it available to more Americans. And that's a really, really big deal.
So continuing that, it has nothing to do with being a generic. It's more of a new classification then.
Correct. It's not a generic. So when you make a small molecule, I'll use Gilenya as an example. Gilenya came out in 2010. It's off patent. And that means that any manufacturer is allowed to make the molecule. In a lab, they can make a molecule that looks on paper like Gilenya, but they don't test it in humans. So that generic has never been tested in human beings. And so we can't prove that it actually works as well as the originator. That's a really big distinction for me. I'm not very comfortable with MS generics, but I've grown very, very comfortable with MS biosimilars. They're completely different classes. That's a good point.
Great, thank you. Question over here? Okay, going around.
Can you ask?
Are you serious? That's a long question. And I don't have my glasses, they're up there. Okay, Dr. B, hi. I'm having Stuart read my question because I recently acquired a really bad stutter. Can you please talk about ataxia and stuttering in the setting of MS? I also recently developed not just drop foot, but what I call drop leg. I I went from using just one cane 3 weeks ago, and I'm now on a walker because my drunk walking has become a terrible safety issue when mixed with my drop leg. Everybody give me a round of applause.
So one of the ways of reflecting on that question is that sometimes nature's too generous. And in the setting of MS, you sometimes don't have just like one bad thing that happens to you. You can actually have several. And so let's take the concept of walking as an example. There are many, many different component parts to walking. One of the component parts to walking is feeling. If you can't feel your feet and you're not looking at them and you walk over a curb, you're going to fall and eat it. Some of you that have numb feet notice that if you walk in the dark, it's not safe, right? You're more likely to fall. Or that if you walk on a grassy knoll, you don't fare as well. You need to be on flat surface. Because on a grassy knoll, you know, the grass is like this, and so your feet can't feel where you are. Another thing that you need to walk is strength, right? So you need your muscles to be able to support your entire body weight. So if I'm walking and I say freeze, I'm supporting my entire body weight on my one leg. That leg has to be really strong to hold up because I'm a really big guy, right? That's not all that you need, all right? When this muscle is contracting, the other one has to let go, right? So that you can move. Because the goal of this muscle is to bring the leg out. The goal of this muscle is to bring it back. And you don't want to do both at the same time. You don't choose for the hamstring to let go. You just move forward. Your brain turns the hamstring off. Except if you have MS, sometimes it doesn't send the memo. It doesn't get the email. And so when you're trying to do this, you're also at the exact same time trying to do that. And now you have a tug of war across your leg. And that presents as spasticity. Spasms, where the leg's bouncing when you don't want it to, a cramp like a Charlie horse, or a stiff leg that's hard to bend. She asked about ataxia. So ataxia is a doctor word that means irregular. And have you ever seen a TV show where someone on the TV show drank too much beer? Have you ever seen, or maybe read a book where they discussed like drinking too much wine, and the person that does that, they start to not walk regularly. All right, because their cerebellum, the balance center, is messed up.
You're not in the box.
And so they can stumble. All right, that's ataxia. And I will admit to you that on one occasion, I maybe had more than one bourbon, and I didn't walk as well, all right, because I temporarily inhibited my cerebellum, and so I was a little off kilter with my walking. And then when the bourbon wore off, then I walked okay. But if the MS causes damage to that same structure, the exact same thing can happen. I tell my patients, if you are pulled over by a police officer and they want you to do the drunk test, which is testing your cerebellum, say, I have MS, please breathalyze me. Right? Just do a breathalyze test because I won't pass your drunk test because I have multiple sclerosis. Actually, I had to go to court once. Actually, I got out of the court, but I was going to have to go to court once to explain to a judge that the 16-year-old had never had any alcohol. He hadn't even been diagnosed yet. He got pulled over and they did a drunk test and they thought he was drunk. He was ataxic from the MS. And so when you're trying to help someone with MS live their very best life, we have to break these things down into component parts. A physical therapist, particularly a neurophysical therapist, will break down walking the same way that Caroline breaks down speaking to figure out the component parts and how to make it better. Let me tell you about a really cool device, all right? I don't have a relationship with the company, but I would be happy to. It's called the Psionic Neural Sleeve. Anybody heard of the Psionic Neural Sleeve? This is really neat. It's not for everybody, but it's really, really neat. It's like a neoprene sleeve, like a wetsuit, like from the bendy crack down to your ankle. And you put it on your leg, and there's 8 electrodes on the quadricep, 8 on the hamstring, 8 on the front, and 8 on the calf. And it's hooked up to your, not hooked up, but it's connected by Bluetooth to your smartphone. And at the right time, it makes your leg do that. And at the right time, it makes your leg do that. And at the right time, it makes your leg do that. And with a special algorithm, it can make you walk near normal. I'm coming back. So that device is really, really fantastic for my patients that have not just foot drop, but also leg drop, where their hip is weak. Now, I'm not saying that's the end-all be-all. I'm simply saying that's a tool or a trick that we can bring to the table to try to help. That's a great question. Thank you for asking.
Can they get that wet, like if it's raining?
I don't think so, but I'm not certain.
Right.
But here in Ohio, that's not so much a problem, Stu.
There's no pool jumping either. All right. Wait, everybody, I'm going to try to do this in order of where I saw hands up. So in a minute, I'm going to ask for everybody else to put hands up because I have MS and I don't remember what you did.
A lot of people are on different drugs, and you've gone from one drug to the other to get the results you're looking for. At what point do you look at your current drug and go with maybe something you mentioned tonight, which is brand new?
Yep.
And
That's a great question. So essentially, the gentleman's saying, when do you switch? Or when do we break up with a drug? So I want to continue on your drug unless one of 5 things happen. As long as one of 5 things don't happen, I want to keep on keeping on with your drug, whatever that drug is, even if I don't like it. All right? So the first thing is no attacks. If you have an attack on your drug, the drug didn't do what I asked it to do. That's like saying if you get pregnant while taking birth control, that did not work. All right? Because the goal of birth control is to prevent an unplanned pregnancy. So if you get knocked up while taking your birth control properly, something ain't right. And if you're taking your MS medicine successfully and you have an attack, that's cause for pause because that was the reason we gave it to you. And so I'm not saying you throw it to the curb, but we're going to do one of 2 things. We're either going to kick it to the curb or we're going to put it on punishment and say that was your one mulligan. All right, you can bring my daughter home late one time if you have a good reason. We're going to talk about it. And the second time, you're not going to see her anymore. All right, I'm just practicing. All right, so that's one of 5 things. The second thing is if you have new spots on your MRI, because new spots on the MRI mean the same thing to me as a clinical attack. So when I'm giving you this medicine, the goal is that you don't have new spots on your MRI because the spot is a doctor word to hide the truth. It's brain damage. That's causing brain damage. So I just want to call it what it is. So no brain damage, right? If you ask the patient's spouse how much more brain damage is okay, they'll put a protective arm around and say, honey, let's go, right? Because no brain damage is okay. We don't want any spots. The third thing is if your exam gets worse. Now, I'm not saying that it always works when we change drugs because your exam gets worse, but if you're having more trouble and you're getting worse, I think that's cause for pause in discussing whether we should try a different mechanism of action because maybe a different drug will fare better. The fourth one is if it's no longer tolerated, right? And drugs can become intolerable over time. I'll give you an example of someone who is diagnosed and put on glutathione acetate. And back in the ancient days of yesteryear, that was a once-a-day shot. And so they do what they're supposed to do, and they take a shot once a day, all month, 30 times, all year, 365 times. 10 years, that's 3,650 times. At some point, they really can't tolerate jabbing themselves anymore. And I've had patients break down in my office crying. They say, I can't do it. Right? And we tell them you don't have to anymore. We're going to switch because that's not tolerable. And the fifth thing is if it was not safe. All right? An easy example of that is you're on Tyruko and you're JC virus antibody negative. You're not at risk of PML. And then you become positive. All right? So now you're at some small risk. And that risk might not be okay with you. And then we would switch. So I want you to keep on keeping on with your drug as long as you're not having attacks, new spots, your exam's getting worse, you no longer tolerate it, or it's not safe. The other time that I always stop and I don't switch is on death. We don't treat past death. So when you die, we're done treating you. Good question.
Good response. Thank you for that.
At what age do they do these test groups? Is the cutoff when they're doing that? And if you're having a reoccurring problem years out, like the foot is turning out and kind of interfering with walking, but you still are relatively strong.
What does that mean? So
They can't figure out what to do with it anyway.
two separate, both very important questions. The first question, say, okay, Aaron, you just talked about all those fancy pants clinical trials where people volunteer and then we study drugs. What's the age cutoff? And so the age cutoff used to be 55, which kind of pisses me off because people still have MS when they turn 56 and 57. And all right, Americans are living into their 80s easily. And so stopping at 55 is frustrating. Now, there are statistical nerd reasons why they do that, but it still pisses me off. I'm really excited that we're now starting to extend trial enrollment into 60. And that's not far enough, but it's in the right direction. And that's brand new in the last couple years. We've started to expand to 58 and now 60. Not all trials, but a lot of them. And I think that's wonderful. Now, she brings up a chronic symptom, just like someone else at the table had brought up some chronic symptoms. If my foot's misbehaving and it's interfering with my ability to walk, what do I do about that? So that's not changing a disease-modifying therapy, that's changing a symptomatic therapy. So we're gonna look at that foot, we're gonna get your shoe and sock off, we're gonna move it around, we're gonna smack it, your reflexes, we're gonna have you do some movement, we're gonna look at the strength. And we may need to figure out, hey, it's spastic and it's curling this way, so we're gonna Botox it, make it go back like that. Hey, we're gonna splint it and put it up like that. Hey, we're gonna send you to physical therapy and get it retrained. And that's not gonna slow the MS down, but it's gonna improve your ability to walk, which is a really big deal. Those are great questions. Thank you.
Thank you.
So I have two questions. Number one, can you speak about remyelination? Does BTK inhibitor do that? And kind of a follow-up part two on there, is there anything long-term on the horizon for reversing spinal cord damage? And can you share with us what smoldering MS is?
That was technically 3 questions, and they're all fantastic.
I
They're
counted
all,
3
they're all
also.
fantastic. The problem is I now have to remember all 3 of them. So the first one was, what about remyelination, right? Today, 2024, we can make MS boring. I'm very proud of that, but we can't cure MS today in 2024. I hypothesize to cure MS, which we can't do yet, but to do it, we would need 3 kinds of drugs, right? Right now, we have 1 of the 3 kinds. One kind of drug that we need is a neuroprotective agent to protect the neurons from damage. Right, and we don't have that yet. We keep trying, and we haven't been successful, but we're still trying. The second one is a remyelinating agent to put the plastic coating back on the wire, right? Because if the immune system strips the plastic coating off the wire and the wire is naked, it can break. And so we want to get an electrician with some E-tape to go in there and duct that back up, right? And we don't know how to do that either, but we're getting a lot closer, right? There's 2 drugs that are kind of exciting these days in research. One is called clemastine, right? And clemastine is a cousin of Benadryl. A lot of my patients have asked for it off-label, meaning they just want to try to take it, and they stop it because it makes them really, really tired. It's like taking Benadryl all day long. But it looks like in some early research that it might be remyelinating. Another drug is metformin. So metformin is a medicine which is not FDA approved for MS. It's a medicine for a different autoimmune condition, diabetes. All right, and when you take metformin, it creates a fasting state in the body, and that helps diabetes. And it looks like that might participate in remyelination, but the jury's still out. We're still working on it. BTK inhibitors do not remyelinate. The third category that we need, we got a lot of. I just went over 30 of them, and those are anti-inflammatory agents that quell the autoreactive immune response. And so my hypothesis is that in the future, to cure the condition, we'll have you on triple therapy: a remyelinating agent, an anti-inflammatory, and a neuroprotective agent. The last question was smoldering MS. Thank you. So smoldering MS is a new term for an old concept. Let me explain it like this. You ever gone to the neurologist, hopefully not me, and the neurologist said, "Oh, honey, you look great. You're doing super duper. All your testing scores are gorgeous. You haven't had an attack. Your MRIs look stable. You're doing super." And you say, "Okay, well then why can't I walk?" No, you're doing fine, sweetheart. You did great. You haven't had an attack. Your scans look great. You're doing super. Yeah, but why can't I work a full day, right? And the person leaves the office feeling kind of gaslit because they were just told how great they're doing, and yet they're failing a litmus test of life. Has anybody ever experienced that? I have a lot of patients that have experienced that. And I think the reason is the neurologist forgot that there's 2 different ways people with MS can get worse. There's 2 different ways that you can develop disability. One way is when you have an attack and don't fully recover. So I'll use an example of, God forbid, you have an optic neuritis in your left eye and you go blind, can't see at all. And then it comes back, but it only comes back part way. And now you have 20/400 vision. You're legally blind, but you can see like shapes and colors. You have accrued some disability from incomplete recovery. And we call that raw relapse-associated worsening, because neurologists are nerds and we want to make up stuff. So we call that relapse-associated worsening, or raw. That's one of 2 ways that you can get worse. The other way that you can get worse occurs very often and very early, but we haven't been honest about it. And it's called PIRA, P-I-R-A, progression independent from relapse activity. In other words, your exam gets worse and you have not had an attack. And we used to talk about that only happening in primary progressive MS or in secondary progressive MS, but that's not accurate. It actually happens as early as you care to look at it. And so a human being recently diagnosed with MS can get worse from two different reasons. And so we have to be honest about that. Smoldering MS is the concept that even when you're not having an attack, even when there's no new spots, the aberrant immune system is slowly attacking your brain. And one of my friends described it as a paper shredder set on low and just slowly ticking in the background. One of the reasons that I'm so sad, blue, and depressed when a doctor stops a patient's medicine because they haven't had an attack is he's missing half the point. These medicines do more than just prevent new spots on the brain MRI. They do more than just cause you to not have attacks. They slow down disability progression, and they can impact PIRA. Not awesome, but they can impact PIRA. And that's why I want you to keep on keeping on. I'm really happy to share that internationally there's a profound focus on smoldering MS and on PIRA. And that's really a giant research focus. And so what you're going to see as we move forward with clinical trials is more focus on that, which I think is going to help patients a lot.
Let's talk about another thing that's on the horizon, CAR T.
Yeah, that's really neat. So it reminds me of like Cardi B, but that's different. So CAR T is a therapy which has been developed to treat cancer, right? Remember when we were talking earlier today about the T cells? And the T cell will see a virus and it will build a very specific mechanism that it targets that virus perfectly. And for the rest of that T cell's life, when it floats around the body, if it sees that virus, it'll crush it. And then that T cell makes copies of itself. And so you're now immune to whatever that virus is because you have very specific T cells against that virus. CAR T therapy is a chimeric therapy. They take a T cell in a petri dish and they do surgery on it and they give it a shape that allows it to identify your cancer. So they take one of your cancer cells and they basically make the T cell identify the cancer cell and then they put it in your body. So they make like a little robot that floats around your body and instead of attacking a virus, attacks your cancer. It finds your cancer and whoops its butt. It can in some cases cure cancer. So you're hijacking the way the T cell works, you're making it do your bidding, which is really slick. And so the thought is, well gosh, maybe we can do that even outside of cancer. What if we could make a T cell that could identify the naughty autoreactive B cell? What if we could make a T cell that could identify the naughty autoreactive T cell and put it into someone's body with MS and have it fly around and clean everything up? And so there's very early research looking at doing exactly that. That's personalized precision medicine. That's like next generation stuff, and it's being tested right now.
Hello, Dr. Boster. Would you be able to speak to the blood lab test that's now available that cause the biometric indicators in people that have MS? And I've heard it being likened to an MRI. If you can compare and contrast and share what the benefits are in receiving that. Thank you.
Yes. But I need to get a glass of water. Don't tell Stuart, he's going to freak out.
I'm not. You're just off camera.
All right, just occupy Stuart so he doesn't realize what I'm doing. Like talk to him or something.
Nita,
Okay,
no
all right.
evidence of disease activity. Let's talk about it.
All right, thank you. So the question was, what's up with this like blood test for MS? So there's a company called Octave, and it's a for-profit company. They're really smart guys and gals, and they've developed a blood test. Now they came to my office about 2.5 years ago, and they said, hey, we got this cool blood test. Want to use it? And I said, where's your data? And they said, we're working on it. And I said, well, call me back when you've done it. And they did. So it's been 2.5 years and they've done amazing research. They've published a bunch of papers and they've proven that they've created a blood test which gives you insights into how your MS is doing. Pretty slick. The blood test is actually 18 different biomarkers, 18 different blood markers, which have been studied extensively and proven to be reflective of MS disease activity. One of them gets a lot of popular press called neurofilament light chain. That's one of the 18 markers. And so someone with MS can pay for this test. It's not covered by most insurances yet. They can pay for this test And it's sent off to a special lab, and they look at these 18 biomarkers, and it gives back feedback on 4 different categories of disease: neurodegeneration, inflammation, and then it gives you a final score called the DA, or disease activity. And it can tell you whether you're in a high, medium, or low disease activity state. And that score correlates rather strongly with new enhancing lesions in the brain or new upcoming attacks. And it seems to be reflective of MS medicine. So if we take someone who's got hot MS, I don't mean they're attractive, I mean their MS is very, very active, and we give them, and so we do the blood test, their score will be very high. And then let's say you give them a mild medicine, a disease-modifying therapy that's not robust, it's just okayish, it'll drop, and you give them a better medicine, it drops more. And so that's very, very exciting. Now, if the test was ubiquitously available through insurance, like if it was covered by insurances, I would probably get it 4 times a year. And I would probably get MRIs a little less often. It's not commercially available yet through insurance. And that's not because of the company's fault. They have to then petition all the insurance companies to approve it. And so right now, patients have to do it out of pocket, and it can be a couple $100. And for some families, that's just a no-no. But I think the future is very bright. And what the company's doing is they're going to insurance products and saying, are you sure? And I think that you're going to see this kind of blood test is going to become prime time very, very soon. Great question. Thank you.
Thank you. So how does that compare to serum neurofilament light?
This is serum neurofilament light and 17 other markers. And they did a study where they looked at just serum neurofilament light against this DA test, and the DA test beat the pants off neurofilament light by itself. So neurofilament light is one of the 18 markers that are being looked at. Very, very cool.
Next.
What do you think of the walking pill, Ampyra? Thank you.
Ampyra. Yep, Ampyra. So in the United States, it's Ampyra. In Europe, it's Fampyra. It's 4-aminopyridine is the drug. And I didn't make up any of these words. So the walking pill, Ampyra, is not a drug to slow multiple sclerosis. What it does is really, really cool, and it deals with 2 horrible symptoms. Some of my patients, they're strong. Their legs work great. And they start on a promenade, and as they walk farther and farther, their left leg starts to flap the ground. And as they keep walking, they start to drag their left leg. And after a while, they have to stop walking because their left leg doesn't work anymore. They have motor fatigue, and they have to sit and wait until their body cools down, then they can walk a bit farther. Some of my patients, if they go outside in August here in Ohio, and it's really hot outside and their core body temperature increases, they start to have all their old symptoms come back, and they start to get dizzy again, and they start to get really weak, or their arm starts to burn again, or they start to lose vision again. That's called heat sensitivity. And those are really yucky, invisible symptoms, and they're very common in the setting of MS. If you respond to Ampyra, which is a pill twice a day, it buttresses against that. You can go out in the heat and nothing bad happens. You can go on a promenade and you keep walking. Now, only about 1/3 to half of patients respond to Ampyra. And even though it's been out for all these years, we're still pretty dumb. We don't know how to predict ahead of time who's going to respond and who doesn't. I used to ask patients to take it for a month to figure it out, and I've learned that you really should take it for 2 months before you give up. And in my experience, and I've now been using this drug for a very, very long time, like 20 some years, you either have a Lazarus response, like oh my Lord, Boster, why didn't you give this to me last summer? And no, you may not have it back. I'm never going to stop my Ampyra because I can do things now that I wasn't able to do. Or are you saying, eh. And if you say, it didn't work, all right, then we stop it. So that's the walking pill. Now, the reason you call it the walking pill is when we tested it, and the company that tested it is called Accorda, and I participated in those trials, we tested it in a very inexpensive, fast way, walking speed, right? So we would have people stand at a line and walk as fast as they could safely for 25 feet, and we would time it. And what we showed was on Ampyra, they could do it a lot faster. But that's not the only thing that Ampyra can do for you. Ampyra can do a lot of different things for you. In fact, most of my patients, if I say, would you like to walk longer or faster? They would say, that's a dumb question. I would like to walk longer. I want to keep walking, right? It actually helps with anything that's heat sensitive. And I'll give you my very favorite example. So there's a family that I'm very fond of. I've taken care of the husband for many, many years now. In fact, our children are friends. And they were in the clinic, and we were just wrapping up a very nice visit. And I had started him on Ampyra 3 months earlier, but I had forgotten to ask him about it. And as I was walking out, doctor's hand on the door, the wife said, "Oh, by the way, Dr. B, you may not remove his Ampyra." And I said, "Okay." And she goes, "I don't think you heard what I said. You may never remove his Ampyra." And so I took my hand off the door. I said, "What do you mean?" When he got MS, he was 18, and they were dating. And he went from being an 18-year-old with an 18-year-old's erection to having erectile dysfunction. It was heat-induced erectile dysfunction. So as he participated in intercourse and as his body heated up, he would lose his ability to maintain an erection. And they couldn't overcome that. And medicines like Viagra didn't work. And so to become pregnant, they had to get semen out. Well, on Ampyra, he's 18 again. Right? Now that's an off-label indication, but boy, howdy, was I excited to give it to those guys. And he still uses his Ampyra today.
So that's why there's a shortfall in babies being born in Florida.
Dr. Boster, can you talk about the microglia again? Are they just up in my brain, eating my brain?
Yeah. So remember, there's two parts to the immune system, right? There's the adaptive, that's the B and the T cells, and then there's the innate immune system. And those are the dumb as rocks guys that are always ready to attack, but you can't teach them anything. And there's a bunch of different innate immune cells, like lots. But the one that I focused on is called microglia, and they are resident to the brain, meaning they only live in the brain. They never leave the brain. And what they're supposed to do is like help out and make everything cool and calm. But when they get pissed off, they literally turn into the Incredible Hulk and they start to eat stuff they're not supposed to, like your brain. And so medicines like BTK inhibitors can turn them off, and that's very, very exciting. It's the first time that we've been able to reach the innate immune system with our therapies. So Stuart used to give people a microphone, but during the pandemic, all things changed. And one of the things we learned about was the safety. So he's holding on to it not to be sassy pants, but because he doesn't want to spread infection.
I said one germ mic.
Can you explain why or how sleep is affected by MS? Why is it so bad?
Yeah. So my grandma used to say, Aaron's not a good sleeper. And sleep is really, really important. And sleep can get messed up pretty badly in MS. So pick a number 1 through 10. 8. Let's go over 8 things that MS can do to sleep. All right. So one of them is people with MS may need to leave the workforce. And when you're not required to be at work by 8, you're not required to get up at 6. So you're not required to go to bed at 10. And everyone else is doing that. And your sleep cycle can shift. And so it's very common that someone can end up being up all night on the interwebs, and then they go to bed about the time their spouse is getting up to go to work. Right? MS can do that to you because of social isolation and by not having guard posts of you got to be at work or you get fired. Right? And so that's a very, very common thing we see in MS. People with MS are at increased risk of obstructive sleep apnea. I don't know why, but they are. And obstructive sleep apnea is where the tissues of the neck, I have to be careful because I have this mic, so if I do that, it's the tissues of the neck relax when you're sleeping, and so they can close. Snoring is you trying to move air through closed vocal cords. That's the vocal cords trying to vibrate, and sometimes it doesn't work. And your body tries to wake yourself up, and that's called sleep apnea. Your brain's not getting oxygen. When we study people with obstructive sleep apnea, they may be asleep, like not awake, able to talk to you for 8 hours. They got 2 hours of actual sleep because they kept waking themselves up. And so they're exhausted. Let me give you a quick tip. If you wake up in the morning and you're tired, that's not MS. MS does not make you tired right when you wake up. You get tired real quick right after you get up. But when you wake up in the morning, that's all the energy you're going to have. If you wake up and you have a headache or you wake up and you're tired, and your spouse says, Lord God, you snore like a freight train, get ye to the sleep doctor because they can fix that, right? And you get restorative sleep. MS can cause your bladder to misbehave, right? And it can do it lots of different ways. So it can cause overactive bladder. So when you have to go like right now, like I'm going to start peeing, please move because I can't wait, right? And you can have accidents because you can't get there in time. Or you may have to get up like a couple times an hour to pee. You have urinary frequency. And then you can have this nasty word called nocturia, which means I get up more than 3 times a night to pee. Well, if you go to bed at midnight and your alarm is set for 6 and you wake up 3 times, you're not getting restorative sleep, right? Because of bladder. You can also have urinary retention, which can be very, very painful, right? MS can mess with your bowels. MS can cause constipation, and MS can cause diarrhea. You're done eating. And sometimes MS can cause fecal incontinence and fecal urgency. Someone can wake up with the need to poop and they can't get out of the bed fast enough to do it. That person's no longer sleeping peacefully. MS can cause pain. When I was in med school, my professors told me that MS didn't cause pain, and they were wrong. MS causes all kinds of different pain. And you are more aware of that pain generally when you're laying in bed still and it's quiet. When you're up moving around, there's lots of stimulation and you're doing stuff, sometimes you can kind of mask the pain or hide the pain. But when everything's quiet and everything's dark and there's no stimulation and you're laying there, sometimes you hurt real bad. And it can feel like you're being squeezed around your belly, the MS hug, the only hug you don't want. It can feel like your leg is burning or it's freezing cold or it's being crushed, right? You can have pain behind your eye. As you're laying in bed with your pillow, you can have zips down your back. There's a host of things and they can wake you up from sleep, the pain. People with MS are very, very likely to get something called restless leg syndrome, which is a form of torture. So restless leg syndrome is never a problem when you're moving. So if you're moving around, you're fine. You don't have any problems. But as soon as you sit or lay down and your legs aren't moving, you develop a compulsion to move your legs. And it builds up and it builds up and you can't ignore it. And finally, it's so bad that you shake your leg for a second and then it starts over. And so sometimes people hop out of bed and they walk around and they feel better. They get back in bed and it starts up again. It makes it nearly impossible to fall asleep. Now, fortunately, there's all kinds of great medicines to treat restless leg syndrome, but it's extremely common in MS. Was that 8? I lost count. It was only 6. We've got to do 2 more. Fine. Let me think of 2 more because I promised 8 things that can mess up sleep. Sometimes people with MS have profound fatigue. It's actually the most common symptom in MS. And sometimes people will take a little nappy nap in the middle of the day for about 4 hours. That's not a nap, that's fracturing their sleep. And so it makes it really, really hard to sleep at night. I'm going to cheat, and the last one I'm going to say is not specific to MS, but it's specific to these things. And a lot of us, in order to decompress at night, we do something in the bed called doom scroll, where you just sit there and you can spend hours doing that. And the light from the phone is waking up the pineal gland and it's forcing you to stay awake. All right, it's keeping you awake. Did you know that the bed is only for 2 things? Did you know that? The bed is only for 2 things. One of them is sleeping and one of them is sex. And if you're doing it right, you should be able to tell the 2 apart, real easy breezy. All right. Now, you should not have a phone in your bedroom. No phone in the bedroom, not if you want to get a good night's sleep. You should not have a TV in the bedroom. That's not what the bedroom is for. The bedroom is only for 2 things. You don't have sex and watch TV at the same time, I would hope. You certainly don't sleep and watch TV at the same time. The bed is not for laying and ruminating and perseverating about your day. That's what I'm guilty of. I had to train myself not to do that. I go through mental exercises to stop. If I get in bed and I don't do my mental exercises, I will think through each patient of my clinic day and torture myself asking if I'd missed anything. And sometimes I'll wake up and I'll go downstairs and get on the computer to make sure I didn't screw up, which is not a good way to get a night's sleep. And so I have to do something special to get myself to calm down so I can do that, because the bed is not for worrying. The bed is for only 2 activities. And you should be able to tell them apart. That's a good question.
1 or 2 last questions from
Yes, sir.
online, please, all right? It's getting late, so unfortunately for all those that are online, please know that this program is being recorded while you're watching it, and it will be published to our YouTube channel in a few weeks. For those who had questions about speech therapy, we had a speech therapist on here earlier, so I'm going to ask you all to wait until we publish these 2 presenters, and you will be able to see what they presented. All right, and as far as the last question that I'm going to ask you is, it was just announced recently that Ocrevus is soon to be available as an injection. And what will be the process to get that injection, if you know?
Yep. So Ocrelizumab is one of the most prescribed drugs in the world for multiple sclerosis. I'm very fond of this medicine, ocrelizumab. It's one of the B cell depleters. We talked about the different drugs today, and we talked about medicines that kill B cells. So killing B cells is a very effective way of treating MS, and one of the drugs that do that is called Ocrevus. And it's an infusion we give in the vein twice a year, and the infusion is about 2.5 hours, right? The manufacturer who makes Ocrevus made a new formulation. It's the same drug, but it's given a different route. It's given subcutaneously under the skin. And the marketing says it's a 10-minute infusion. Well, but it's really, by the time you get started and finish, it's about an hour to an hour and a half. But that's still shorter than IV, right? And so the intention of the manufacturer is not to replace IV. That works great for lots and lots of people, but options are awesome. Now, this is not an infusion that you can do yourself. You have to come into an infusion center and they hook this up and they infuse you under your skin. And so it's rapidly becoming another option when treating people with that medication. So you'll have choices of which one you take. And the intention by the manufacturer, it's still very early days. It hasn't even been 6 months yet. And so CMS and Medicare don't get involved until about 6 months in. But the intention is that they create options for patients, and so that the patient and the doctor together can figure out which of those works better, which is pretty slick. So options are always very, very good. Great question.
Awesome. And now my last one. Did everybody enjoy the program? That's even better to know about. So we'll be back again one day with my buddy here, as long as he learns to stay in the box.
You can't put baby in a box.
It's a rectangle.
Yeah.
It's a rectangle. Not keep baby in the corner. I don't have you in a corner. Again, we provide these for a reason. We want people to learn. This is a great audience tonight. I hope to see you all again next year, because it won't be 2024, but it will be 2025 when we do see you again. And so I want to thank you all for being here tonight. Aloha. Thank you. Be well. Bye.